Hello, I am Dr. Daisy M. Medina, a diplomate of the Philippine Academy of Family Physicians, and this is the module for evidence based decision making. Evidence based medicine, as defined by David Sackett, is the integration of individual clinical expertise with the best available evidence from systematic research and patients' preferences and values. EBM starts with a question based on a clinical dilemma that we encounter during our interaction with the patient. As a review, in the first step of the EBM cycle, we ask. Here, we formulate a focused clinical question which should contain the necessary components such as the population, exposure, outcome, and methods. In the next step, we acquire a relevant article that will help us answer our focused clinical question. Here, we search the databases for the best current evidence. The third step involves the appraisal of the article that we found. This is followed by applying the information that we obtained from the article to our own patient. And lastly, we evaluate our efficiency in executing steps 1 to 4 of the EBM process and seek ways on how to improve it. What we are going to discuss in this module is evidence-based medicine on harm, through which we answer the question, should I advise my patient to avoid a particular behavior or treatment? Clinical questions on harm involves asking about how a patient characteristic or behavior may lead to an unfavorable outcome. A patient characteristic or behavior that increases a patient's chance of developing a disease is what we refer to as a risk factor. For example, cigarette smoking is a risk factor for developing coronary artery disease. The study designs utilized to establish the association of risk factors with the development of particular diseases are case control or cohort studies. In a case-controlled study, patients with the outcome or disease are first identified as cases. Then, a group of patients without the disease, matched for certain characteristics, are identified as controls. The presence or absence of exposure or risk factors in both groups are then determined retrospectively. On the other hand, in a cohort study, groups of patients with and without the exposure or risk factor are identified, and the development of outcome or disease is observed forward in time. A cohort study can establish only one or a limited number of risk factors. For our clinical case scenario, we take the case of a 55-year-old female consulting because of menopausal symptoms. She was previously advised by another doctor to take hormone replacement therapy, or HRT, for relief of the said symptoms. Our patient has no personal or family history of breast cancer. However, the patient is concerned about developing breast cancer with the intake of HRT. Hormone replacement therapy is recommended currently for the management of menopause-related vasomotor symptoms. However, it should not be routinely offered to women with history of or to those at high risk of developing breast cancer. Based on the clinical dilemma depicted in the case scenario, we formulate our focused clinical question. So first, we have to identify the P, the E, the O, and the M from the case. For our population, we have menopausal women. For our exposure, we have hormone replacement therapy, or HRT. For our outcome, it's development of breast cancer. And for our method, we have to look for a case control or a cohort study. To state the focused clinical question, among menopausal women, how strongly associated is hormone replacement therapy with the risk of developing breast cancer in a case control or a cohort study? From our search in PubMed, we found this article entitled A Case-Controlled Study of Breast Cancer Risk Factors in 7,663 Women in Malaysia, conducted in 2017 by Tan et al. Now we appraise the article that we have acquired from PubMed. The steps in critical appraisal of an article are as follows. First, we appraise its relevance. Then we appraise the validity of its methods. Next, we appraise the results. And lastly, we appraise the applicability of the results to our own patient. In appraising relevance, we answer the question, is the objective of the article on risk factor addressing our clinical dilemma? So the study by Tan et al. Reported on the association between clinical, exogenous hormonal, menstrual, reproductive, anthropometric, and lifestyle factors with breast cancer from a hospital-based case control study of 7,663 women in Malaysia. Through this objective, we specifically look into how well the P, E, O, and M of the study corresponds to the P, E, O, M of our own focused clinical question. So from the study, the population or participants were women diagnosed clinically with breast carcinoma as cases and healthy women as controls. For exposure, the study included a variety of factors, including exogenous hormones, under which the hormone replacement therapy is included. The outcome is breast cancer as well. And for the method, the study is a case control study. So based on these, we assess that the PEOM of the study corresponds well to the PEOM of our focused clinical question. Since we found the article to be relevant to our clinical dilemma, we then go to appraising validity. In appraising validity of the study methods, we have 3 guide questions. First, were there clearly identified comparison groups? Second, were there exposures and outcomes measured in the same way in the groups compared? And third, was there a temporal relationship and was follow-up sufficiently long and complete? Let us go through the 3 validity guide questions one by one. So for the first question, were there clearly identified comparison groups? As we have mentioned earlier, risk factor studies can be a case control or a cohort study, wherein there is a comparison with a control group. In a case controlled study, the comparison groups are those with and without the outcome or disease. In the article by Tan et al., all patients diagnosed clinically with breast carcinoma were recruited as cases, and healthy women aged 20 to 74 years with no personal history of breast cancer were recruited as controls. For the second question, were the exposures and outcomes measured in the same way in the groups compared? Measurement of exposures and outcomes must be similar in both comparison groups. In a cohort study, the key issue is ascertainment of outcome. Investigators must observe for and detect disease using the same strategies in the 2 groups. If a participant with a risk factor is observed more diligently for the outcome or disease, there will be a higher detection rate of the outcome, and this may lead to an increased incidence of the disease among the exposed group. On the other hand, in case-controlled studies, the key issue is ascertainment of the exposure. Patients with the outcome may be more likely to recall an exposure than patients in the control group. Interviewers also, if aware about which participants have the outcome, may tend to probe more for the presence of exposure risk factor. Both may lead to a higher rate of exposure among the group with the outcome. These are all what we refer to as surveillance bias, and strategies should be utilized to minimize it. In the study by Tan et al., exposure to HRT was defined in the study as ever used oral contraceptives and HRT, meaning used for at least a month. Here in the study, all participants were interviewed by trained interviewers at the hospitals. All the participants completed questionnaire, That included items related to demographics, personal and family history of cancers, history of breast surgery, menstrual and reproductive history, use of oral contraceptive and hormone replacement therapy, breast cancer diagnosis for cases only, and history of and motivation of attending mammography screening for controls only. So, based on this, we answer yes to the second question. The third validity guide question is: was there a temporal relationship and was follow up sufficiently long and complete? For an exposure to cause and effect, the exposure must have occurred prior to the outcome. In the study by Tan et al., ever used implies intake of hormone replacement therapy in the past. Measurement of outcome may require sufficiently long and complete follow-up in cohort studies. Sufficiently long meaning long enough to detect outcome, and follow-up must be adequate to lessen the chance of underestimating the effect. Since we answered yes to all three guide questions for validity, then we say that overall, the study is valid. Now we move on to appraising results. In appraising the results, we have to answer the first question. What is the magnitude of the association between the risk factor and the outcome? In cohort studies wherein the outcome is observed forward in time, risk ratios are reported as the measures of association. In case-controlled studies, odds ratios are reported as measures of association between the risk factor and the disease. Odds ratios is the ratio of the odds of the disease occurring if the exposure is present to the odds of the disease occurring if the exposure is absent. So, an odds ratio of more than 1 means that the exposure caused harm or disease, and if it is less than 1, the exposure caused a reduction in the occurrence of harm or disease. In the study by Tan et al., the odds ratio of breast cancer among those having ever used hormone replacement therapy is 0.52. Since this is less than 1, then we say that HRT did not cause and in fact reduced the occurrence of disease, specifically breast cancer. In appraising the results, the second question is: was the estimate statistically significant and dose-response gradient present? For an odds ratio of more than 1 to be statistically significant, both the upper and lower limits of the confidence interval should be greater than 1. This is for us to conclude that the risk factor indeed caused the disease. If one of the limits is less than 1 and the other is greater than 1, then we conclude that the effect of the exposure is uncertain. In the study by Tan et al., the odds ratio of developing breast cancer among those who had exposure was 0.52, with a 95% confidence interval of 0.44 to 0.61. Since both the upper and the lower limits of the confidence interval are below 1, then we say that it is statistically significant that hormone replacement therapy does not increase the risk of developing breast cancer. The dose and the type of hormone replacement therapy was not specified, so we can't really say that there was a dose-response gradient. After appraising and interpreting the results, we now move on to appraising applicability, which is the last step in the critical appraisal of an article. For this last step, we have to answer two questions. 1. Are the study patients similar to my own? And 2. Should I attempt to stop the exposure? Are the study patients similar to my own? For us to be able to answer this question, we have to look into how similar the characteristics of our patient is to the study's inclusion criteria. In the Tan et al. Study, majority of the women included were between 45 to 65 years of age. These are the women who most likely suffer from menopausal symptoms and who will benefit from hormone replacement therapy, as in the case of our 55-year-old menopausal patient in the case scenario. The second question is, should I attempt to stop the exposure? There are three questions that we need to have clear answers to in order for us to decide on whether to stop the exposure. These are, how large and precise is the risk of the harm? What are the consequences if I withdraw the exposure? And do I have any alternative for the exposure? These are what we know so far. Hormone replacement therapy is still the best treatment for menopausal related symptoms based on clinical practice guidelines. Our 55-year-old patient can benefit from HRT. And from the study by Tan et al., HRT does not increase the risk of developing breast cancer. So with all this information, we can now advise our patient regarding use of HRT and address her fear of developing breast cancer. Shared clinical decision making is important in providing individualized or patient-centered care. Our patient must be informed well on her concern about developing breast cancer with the intake of hormone replacement therapy to enable her to make a decision on whether to take it or not. In risk factor studies using case-control study design, the association of several risk factors to the outcome can be established. Like in the study by Tan et al., they were able to show that aside from HRT not being associated with breast cancer, soy in the diet, physical activity, and prior breastfeeding reduce the risk of developing breast cancer. These are my references. Thank you for listening.